क्या हुआ? Good morning, good morning. Please join with us. Last time you were there? Yeah, sure. I think there is some revision of the same topic will be there probably. Reason being, YouTube पे आ चुका है ये नहीं? हाँ. Okay. Yeah. Yeah, that was different. So now we are moving to the topic what is called ECG to ablation. Basically, this is one book which I have published. It is basically meant for the persons who have done the DM cardiology and who want to pursue cardiology, electrophysiology, cardiac electrophysiology. For that, we have made. This book is a very concise book and way to approach point of view means if you are struggling the language of EP and practice, then it will go to book. You will get all the information how to start. It is not the theoretical discussion; it's the practical way to EP cases. So far we have gone for the basics, how to start from EGM. Second part we have gone the Brady protocol, and third protocol we have gone for the what you call Brady, and today we are going for the Tachy. Tachy evaluation means the program we use the word PES, program electrical stimulation, and in the program why it is coming like this. So in the programmed electrical stimulation, we are where it is. Sorry. Program electrical stimulation, we are discussing incremental, decremental, and extra. So these are three protocols. Incremental means by giving the particular number of beats, then we are changing the cycle length, and then again means every cycle length 8 to 10 beat, 20 beats we are giving, and train of the beats are going on. In the ramp the part two, we are just starting the where the means particular every beat by beat we are changing. 120, 130, 140, 150, like the cycle length will be changing every beat. And third is the extra. So we are giving a train of beats so that the rhythm should get stabilized with that particular rhythm. Like patient own rate is 62, we are pacing at 70. After that, we are giving one extra. So S1, S2, S3 protocol we say. So S1 is the base cycle length, S2 and S3 is the additional cycle length. And why we are using, so there are two things. One is that we want to see the property of the myocardial conduction system, and finally, whether there any tachycardia abnormal tachycardia or circuit is there or not. And that will be done when we are checking each and every parameters. Means refractive period is fine, means the AV node or AV node, they are healthy. When we are going to myocardium, whether it is a very hyper excitable versus normal excitability is there. Third comes whether the initiation of tachycardia is happening with the extra systole, means one beat is initiating it, and what type of circuit it is there, that we usually check. So in this, and when the tachycardia is came, then we have to see whether it is terminating or not. So like that it goes. So initiation, termination, and differentiation of different type of tachycardia. PSVT is there. PSVT include the AVRT, AVNRT, atrial tachycardia. So there are protocols. Okay, it is atrial tachycardia. So we have to find the focus. If it is AVRT, AVNRT means there is some pathways are there. In AVNRT, the pathway will be in and around the AV node, or it is usually called intranode. Means in node there are two types of fiber. One is fast and slow pathway, and we have to just terminate the slow pathway by giving the ablation. In the pathways means which we use the word AVRT, atrioventricular reentrant tachycardia. Here the circuit is outside the AV node most of the time, and it is pathway means it is the fibers which are connected from the atrium to ventricle, mostly from the endocardial surface, not from the epicardial, mostly. And we have to locate the things. So depending upon the type of atrial activation or ventricular activation, we anticipate. Sometimes the ECG will give all the information. When the ECG, there is a delta waves are coming. So by seeing the delta wave, we can say that this is coming from the left side or right side, or it is from the anterior, posterior, or it is from the near to the CS or near to the AV node. Like that, all those information we can detect by seeing the ECG, provided it is having the pre-excitation pattern. So pre-excitation pattern, what is there? WPW syndrome. Means, the delta waves are there. Short PR, less than 120, and there is a slurring of the QRS followed by the QRS which is more than 120. So if these three criteria are means the short PR followed by delta and QRS more than 120, it is called pre-excitation with delta. So that is part of the WPW syndrome. But there are some conditions in which you will not get the delta wave, like LGL syndrome, Long-Gannon-Levin syndrome, which is basically that the patient is having some short of AV, fast AV conduction, and that will be leading to the short PR interval, but there's no delta wave. And the third pre-excitation pattern, we use the word for the MAHIMs. So there is a accessory pathway or accessory AV node, means one AV node is at the atrium ventricle in the center, but sometimes the same fiber type of behavior will be on the lateral aspect of the right and left ventricle. So we call the right lateral pathway. And there is a AV nodal type tissue in which the conduction will be decremental, means the time you are increasing the heart rate, it will be getting slow, and it is through the lateral part, and it will be unidirectional. It will not bilateral from the atrium to ventricle. So we use the word atriovascular pathway also. So that is called MAHIM. So these are three types of pre-excitation that we are using, and why we are doing the EP study. So EP study we are doing to induce the tachycardia and see the property of the conduction tissue and this. Now coming to the second part, how we are going to do. So there are two protocols, we call atrial and ventricle protocols. So when we are doing from the atrium, we are giving the pacing rate and seeing how the SA, AV and conduction systems were. And then we go for the ventricular pacing from the two sides, either from the right ventricular outflow tract or right ventricular apex. We pace the ventricle and see how the conduction is happening. So far, as a novice, you know that most of the time conduction is happening up to down, but it is possible that the ventricle also conduct from B to A also through AV node. Most of the time through AV node. You see, it is a bidirectional pathway, but mostly the current goes from the up to down, as say AV node and ventricle. But sometimes the VPCs, which is forming in the ventricle, it can conduct through the same AV node retrogradely. And that's why VA conduction is also one of the part in a normal conduction system. If the conduction is happening at 300, the same thing will be happening at 300 or even 290 also. Sometimes the VA conduction is very fast, sometimes VA conduction is very slow. This property is very essential when we are inducing the tachycardia, because sometimes the VA conduction is very, very poor. By seeing that, we can say the patient may not be having AV-RT, because AV-RT require the good VA conduction also, either through the pathway or through the AV node. Either of the things should be there. If a poor VA conduction is there, means the patient may not be having AV-RT as one of the possibility. It can be, but less likely. AV-NRT will be more probable, or atrial tachycardia may be more probable. So PSVT with three type of possibility: atrial tachycardia, AV-RT, and AV-NRT. So these three things we can just anticipate by doing the VA conduction and AV conduction, and we can make, okay, most likely, if tachycardia is coming, we will certainly pinpoint what type of tachycardia is. And we perform the EP study for the ventricular tachycardia, in which established ventricular tachycardia is the possibility we start from atrium, and if it is a PSVT, we will start from the ventricle. So it is like a reverse, okay? And the same three type of pacing: extras, decremental, and incremental, okay? So this is the incremental. Last time we are seeing, if you can see the cycle length, the distance between the each beats, you can see 8 beats are there. The next 8 beats are more faster. Then next 8 beats is again faster and faster, like that. So this is called the burst pacing or incremental pacing. Means the heart rate is increasing at every chain of the beat, and this is the normal what we are getting. So you can see this here's an S and H. So S means stimulus, A means atrium, H is the his, and then V. So like that, we are going to see the S1 interval like that. It will be changing. So we measure the each beat to beat, whatever the conduction time, and we take ramp pacing means we are fasting. Usually we don't perform most of the time this ramp pacing. So decremental conduction is there, but normally decremental pacing we are not doing in the EP lab for you. Okay, we are mostly doing the incremental and extras. When we are seeing extra means S1, S2, S3 protocol. When we are seeing burst pacing, straight pacing, two words, straight pacing and burst pacing are same, or incremental pacing is same. These three terms are basically meant that we are giving a train of beating at a faster rate every 8 to 10 beats. We are changing the cycle length. Sometimes 200 cycle length. First we have done 300, 280, 270, 260. So train of cycle. Matlab bundles of particular beats we are giving. Okay. Decremental is usually not preferred because it initiates the atrial fibrillation or ventricular fibrillation. So it is not a preferred tachycardia. This one. Extras, if you can see, sorry. So this is the extras you can see. Sorry. So you can see there is a cycle length we have taken. We have taken means the patient own heart rate is around 200, 400 cycle length. Means 400 means around 150 heart rate. So we have started the pacing at 380. Means the more cycle length should be shorter than the whatever the cycle heart rate. So we are pacing at 180 heart rate up to a number of beat, 8 beats we have given, and after that one extra. So this is where stabilize the cycle of the heart and then give extra. So extra will fall into the refractory period up to means either into the excitable or refractory period. These are two periods in which if it is finding to conduct, it will give the contraction. Sometime it will go in the refractory period, it will not conduct. So we'll say, okay, the myocardium or the tissue has reached the refractory period, means the tissue is excitable or inexcitable. And we are seeing the property also, how it is conduction is happening. When we are giving slow beat, it is taking more time. We call it the decremental. If it is taking same time as the conduction, we call it non-decremental. These two terms we are using in the cath lab. Decremental means if you are giving 200 rate and they are giving 300 rate, so at 200, the conduction is taking 300 millisecond. When you have increased the heart rate 300 to 200, it is taking 400 milliseconds. So it means the, the time you are increasing the cycle, means you are increasing the heart rate, it is taking more time to conduct. So this type of property we see in the patient of AV conduction. AV conduction means jitna, the faster you get the beat, it will take more time to recover. Okay. So like that it goes. So here you can say that drivetrain has been taken S1, S2, S1, and there are 1, 2, 3. S4 means we are giving 3 extras. It is not that 4 extras we are giving. Sometimes a misconception is happening. The S1 is the stabilizing chain of beats, what we are giving. And after that, the extra beats number 1, 2, 3 at a particular space. And now coming to the one of the important thing where we most of the time people struggle, refractory period. So refractory period is the, if you go by the terminology, refractory means it is not going to conduct or it is not going to excite. Either of the things you can say. So in our EP lab and in one is called cardiology and one is called physiology. So physiology means what we have been taught in our MBBS time, refractory period, and what refractory period, what we are measuring in the live alive human being is somewhat different. So relative refractory period, functional and effective. These are three terminology we use. Effective refractory period and absolute refractory period are somewhat different, but for the practical purposes, we say ERP or effective refractory period and absolute refractory period are almost same. Means at a level, or you can say at a particular point of stimulation, the myocardium will not get excited, whatever you give. Okay, so it may be that up to 270 it is conducting. The time you are going to 250, it is not conducting, or 260 it is conducting, 250 it is not conducting. So you can say that 250 is the refractory period. We use the word ERP. effective refractive period, and it is same that ARP, effective refractive period. But it was conducting till 260. So what is the terminology we will use for the 240 to 250? 250 not conducting, 260 conducting. So what is the terminology for 260? Hmm? No, that is called functional. Up to that, it is functioning. Just if you want to remember, it is the functioning up to 260, means it is able to go. Now, third word use relative. When you are going to say the part, but the patient is having a relative refractive period. So any tissue, you have given 200, 200, 200, 200, 200. Now, at one level, you will see 200, it is taking 10 milliseconds. Matlab, the time it is taking latency. Latency what we means that cycle length. We have given heart rate of 280, 280, 280, and the tissue is taking 280, 280. There is no gap in between. Are you getting this point? It is having no latency. So when the latency comes, we call it a reflect. Means it is now entering in a zone of refractory period. So that is called relative refractory period. When the input, what is stimulus you are giving, and the output is taking some gap. Gap means there is a time in between the stimulus and the second excitation. That latency period is called the relative refractory period. So you will say 280, 280, 280. Now, after some time means when you are going at a particular heart rate, it will 270. It is taking some time and then activating. So we can say the patient, the tissue has gone to the relative refractory period. And now you are started seeing that now it is taking time. It will sometime stop conducting also. Is it there or not? पहले बोलेगा मैं थक गया हूं, दूसरा बोलेगा मैं करूंगा ही नहीं. So these are two phases. Till it is saying मैं थक गया हूं, that is called latency period, and that will be visible in the stimulus also, and we will use relative refractive period of the tissue has reached. And the time it is saying I am not going to do, we will say it is a effective or effective refractive period or absolute. And before that, what it has conducted, we will say functional. So these are three terminology. Most of the time people get confused. If it is becoming lethargic, means it is feeling lazy, latency, relative. Till functioning with laziness, it is called functional. And the time it is stop conducting, it is called effective or absolute refractive period. Okay. The same thing I have done. The point at which the input of the signal start latency, it is called to the relative. And how to identify all those things. So S1, S2, S2, this is called the late phase of the third phase of action potential. Action potential, whatever we are seeing, it is a tissue, except for the AV node and the SA node, they are having calcium channel dependent conduction. This is also important concept. The SA and AV node are calcium channel dependent action potential. Rest all the tissue, either it is a Purkinje's fiber or myocardium or RBP or all are having the sodium dependent channels, fast activation and all and none phenomena. SA node calcium will be going, that's why it will having a very what you call smooth curve. Here the curve will be having fast conduction. You can see this gone up and then it is taking time of recovery. Recovery time is, we can say this is the action potential, the depolarization and the repolarization time is taking some time. But when you are coming to the what you call SA node, it will be having a sinusoidal. Slowly opening, slowly closing. That also will be coming later on. So ERP functional and AI action. So the time it is reaching to this S2 level, we say ERP. So ERP and ARP is almost same, and the time it is conducting is called functional. And if you are seeing from the ECG point of view, if it is falling at the initial part of the T wave, it will not conduct. Mid and later part of the period will be taken as the period in which you can give a supra threshold stimulation and it will start activating. It will not on the normal threshold. Normal what we are when we are pacing, the threshold we find 0.5 is the threshold. So you stimulate at 0.5 double kya hoga 1. So at 1, it will be activating. If you want to give at 0.5, it will not take. So supra threshold will excite up to a level that is called functional. Okay. So here the refractive period is that is a relative refractive period has started. And there is one period in which it will be supra normal period where the it will give low threshold also it will start exciting. So it happens usually after the what you call action potential, sorry, depolarization is complete, repolarization is completed. That small window is there in which the every tissue is ready for the excitation to give, immediately it start giving the, so that is called supranormal period. Okay. So here, the 4 phases of latency I wanted to show. See, here you have given conduction. Here, this is called stimulation. Okay. So if you can, sorry. Chalo. So A, B, C, and D. What I was discussing, A, the stimulus, he is the stimulus. Okay. You can see this stimulus. And there is this is called activation of the tissue. It is happening immediately. Here, stimulus has given, you see, and after that, the tissue is taking time. It's saying, I am now fatigued. I will still work for you. Supra threshold, give some extra salary, I will work for you. After that, it has again conducted, there is some latency. And after that, it is, अब मैं काम नहीं हूँ, तुम कितना भी salary दोगे, I will not work. So this is the 4th phase. So if you can say this is the normal conduction is happening, here the latency is started happening. This latency period means the patient, this whatever the extras we are giving, S1, S2, it is reaching into the relative refractory period. This is the, if I have to say, this is the FRP, functional refractory period, and then it is the ERP. Okay. So all the three has been here. You can see S1, if it is S1, S2, this is a, what is this? Relative. This is relative. B is relative. This is the functional and this is the ERP. Okay. So when V1 and V2 is equal to S1, S2. So this is V1 and V2 is same normal. Onset of the latency, here the latency means V1, V2 is more than S1, S2. Then it is what you call RRP, relative refractive period. This is FRP till last bit which has been conducted, and the time it is not conducted is called ERP. Okay. There is one condition in which usually what happen at a particular heart rate, the conduction will start hop, matlab ERP you are saying, and ERP after that, there's no conduction is happening like a AV node. You are giving a atrium followed by ventricle, atrium, ventricle, atrium, ventricle. But at one time, you will see ventricle conduction is not happening. Okay? Is it there or not? And after some time, again, it is happening. When you have started a heart rate of 400, it was conducting 380, it has stopped conducting to the ventricle. And you have done around 360, again start conducting. Is it possible or not? I'm coming again. You are started, we call AV conduction study we are doing. We have started a cycle length of 400, it was conducting. You have given 380, it was conducting. 360, it has stopped conducting to ventricle. 360. Then 340, it is start again conducting. Is it possible or not? It is possible. Yes. And why it is happening? That is, this is called gap junction, gap phenomena. So gap phenomena is one of the property of AV conduction tissue, in which two tissues are there. One is atrium and second is AV node. Both are having a different refractive period, and one refractive period is separate. One refractive period is higher than the this one. So what will happen when you are pacing at faster rate? Latency will happen. Is it there or not? It will enter into relative refractive, functional, and finally ERP. This is the normal pathway. So when we are doing at a faster rate, the AV node is not able to conduct down. Its refractive period has come. And you are saying, okay, now there is no conduction. So this is the ERP of AV node. All of a sudden, when you have increased the heart rate, the conduction of the atrium, because it has to come from atrium to AV node, atrium latency period has happened. It has gone to ERP, RRP. It is taking more time. It has given 20 millisecond gap. इसका 20 millisecond, due to 20 millisecond, it was not able to conduct. This gap has provided the conduction to the next tissue. So there are two tissues which are serially connected, having a different ERPs or ARP, whatever is it. But the ARP of the first tissue has led to the first the gap has come in. You are saying at 360, it was not coming, 340 test come. So the RRP of the first tissue has provided the conduction to the second tissue because there was a delay in conduction, and this delay has provided the conduction to the next tissue. Are you clear this one? Because AV nodal tissue is having a decremental conduction. The faster the road, more the gap it will take. Is it clear or not? And when you are coming to the atrium is not having that one. It's one all and none femur. The time you are faster, it will conduct, stop. But in AV node, the time you are increasing the heart rate, it will take more time to recovery. Okay. So gap phenomena is a means we can say it is not an abnormality. We are seeking 360, not 100, 340 conduction. So don't take that the tissue is abnormal. It is a normal, what is called the gap phenomena is not an abnormality, interplay of two conduction velocity and what is called refractory period at two different level. One may be atrium and the other may be AV nodal. And the proximal delay allows the distal recovery is a fundamental concept of the gap. So the latency, what is happening in the first tissue is providing the conduction to the, it is giving the more velocity to the next conduction. So this is the gap phenomena I was showing you. S1, S2, 320 blocked. S1, S2, 290 conducted. And again, S1, S2, 270 blocked. So till now, before this, there was conduction was happening, 320, we are blocking, that is okay. But after reducing 290, why it is blocking? So this type of phenomena, when you are seeing in the AV conduction, you should be. That's why you may be seeing when GJ will is doing, he will conduction block. After that, he will give one more extra second beat. If it is conduct, okay, ERP of AV node has come. Immediately, he will not write first one beat, second beat, and then it's okay if ERP has come. Because it may be possible the earlier tissue is not conducting. That is also possible. Okay. So gap phenomena, what are the things required to happen? Gap phenomena, at least two structures with a different ERP. Both the tissues having a different ERP and should be connected in series. It should not be parallel connection. It is going from one tissue and then the other tissue. Both should be in the series. And third, the distal structure. Distal structure means AV node in the case of AV node in the case of atrium, because atrium followed by AV node followed by his bundle and then RBB, LBB. So distal structure ERP should be more than the proximal structure. Proximal can conduct very fast, but distal is not having that. If it is there, then it will happen. So most of the time, AV conduction tissue will be having this type of things. So we do the program electrical stimulation, V1, V2, V3 protocol, A1, A2, A3 protocol. And this is important, measure the cycle length at which drivetrain we are giving S2 deliver closer to S1. And atrial and ventricular tissue, the faster the stimuli, the shorter the refractory period. This is important. This is called non-decremental. Faster the stimuli, the shorter the refractory period. But when you are going into the AV node, faster the stimuli, the longer the refractory period. Okay? I mean, jitna usko fast kare utna zyada it will take. And the reason is, it is a calcium channel dependent action potential. When it is a SA nodal dependent further, it will be faster. It will, refractive period will be shorter. Okay? So this is called decrement. You can see A, H, A, H. So when you are increasing these two and these two is coming the lower side. This is the stimulation curve. Okay. So the gap between this and this different is this is longer gap. This is shorter gap. So when you are shortening, what is happening? Here you can see this is A, H. A and H. A means atrium, H means his. Here A, H. Here A, H. Here the A to H has increased. When you are reduce the cycle length, it has increased. Means it is decrementing. Is it clear now? Just 1 minute. Is it clear now? What do you mean by decrement? How to see it? AH actually, when you are reducing the cycle length, it should take more time. See, it is decrementing at one level only. It is not at every level. You can see only the AH, this AH has increased. So this is called decrementing. When you are increasing the cycle length, here the cycle length may be 500, here it is 480. At 480, it is increasing. So this is called decrement. It is decreasing on the incremental pacing, the conduction is taking more time. That is called decrement. Okay. For you, it is very essential. Okay. You can see the same thing I am showing it. You are able to understand now the cycle length, this one, this AH, and this AH, the 400 cycle, 380 we have done, cycle length has been reduced, heart rate has been increased. And what is happening here? The 210 was there. Next is 210, and third is 290. Okay. So this is called decremental conduction. And then we make the curve. And you can say RRP, FRP, ERP. This curve always like this one. RRP means latency has started. FRP, last conduction. ERP, not conducting. So when the tissue will be having, you can see the cycle in 600, 550, 500, then 450, 300, 400. At 400, it started having RRP. RRP means where latency has started happening. Up to FRP, it is conducted, and then ERP, there is no conduction is happening. Okay. So this is a normal antograde conduction curve. Here, what is A1, A2, and H1, H2 we are measuring. Okay. Now, decrement, discontinuous curve means at one time you will see reducing, and after that, immediately there is change. What is happening? ये नीचे जाना चाहिए था ना, जैसे इसमें देख रहे हो कर्व बढ़ता चला जाए. At this level, it is curve is going up. Here, all of a sudden, there is a break. It has gone up. What does it mean? One is continuous curve. Continuous one, the conduction, it is taking slowing, and going. Okay. But all of a sudden, it is going and there is something has happened. It is going up immediately. In one, you can see here and here how much gap it is there. Around 40 to 50. So this is called jump. Jump बोलते थे ना, यही jump दिख रहा है. सीख रहे? This is called jump. What happened? It should go hand to hand. 50-50 जब जैसे 10 निकाला, 20 आया, 30 आया. But when you are reducing the A1, A2 by 20, and at the same time the AH interval increases by 50, it is called jump. And jump means it is jumping from one fiber to other fiber. The narrow gauge has changed to the broad gauge. ट्रेन के बारे में पता है? हाँ. So narrow gauge चल रहा था, broad gauge में चला गया वो. It is taking more time. Okay. So slow pathway, fast pathway, slow pathway चला गया. So this is called discontinuous conduction. Or fast pathway, all of a sudden it has gone to the aberrant pathway. AB nodal की जगह पर patient is having bundle of Kent से pass करना start कर गया. So you will see narrow, broad. So QRS will become broader. Means it is not going to the AV node, because anything which is going through AV node, it will be having a narrow QRS. This is a principle that we have to learn. If it is bypassing the AV node, it will be becoming broader. So it has passed to the aberrant pathway bundle of Kant and QRS is white. So this type of discontinuous curve, when we are measuring, it will give the patient is having dual pathway, and we can know what is the refractive period of that pathway. So it will conduct up to this one. After that, it will again stop. So we can say the refractive period of this one is of the slow pathway. The SERP, slow pathway refractive period is around this one. Okay. So ERP and FRP. Usually we don't measure it. We only need the FRP. Sorry, ERP. At what conduction it is not happening. 20 minus kar do, that is the FRP. So 400 to 20 is the, just think about ERP as well. So what will be the FRP? 400 to 40, 20 plus. 400 to 20 is the ERP. So what is the FRP? 20 plus तो कितना होगा? 220 का 20 plus? Oh my God. No. See, 400 to 280 means 400 cycle length, extra there 280. Okay. It is stopped conducting. Okay. So when it will be conducting? When it will be conducting? FRP, what is the FRP then? Yes. So 400, 300. Till 300 it is conducting, 280 blocked. So if you have to write in this one FRP, you have to write 400 by 300 and 400 by 280 ERP. आज तक लिखा नहीं होगा तुमने? हाँ, तो आगे से लिखना। जैसे वो बोलेगा ERP, तुम भी उसके साथ लिखना FRP. ओके, सो ERP यूजुअली लिखेगा 400 by 280. वो 280 नहीं बोलते, वो लोग बोलेंगे 280 लिख दो, लेकिन 280 नहीं, यू हैव टू ऑलवेज राइट 400 by 280. मींस 400 is the cycle length and 280 it is blocking. 200 extra per it is blocking. Okay. So same thing I was showing here. Like 400 to 280 it is ERP, and 400 290 10 cycle length above is ERP. So why we do it the right atrial pacing? So I think वो लोग wait कर रहे हैं. We'll go. So I think for today it is more than enough. So in next class we'll be again going to the ERP jump, some what we call S1 S2 A jump. What we call as a, this is a word we use commonly in our EP lab. Jump has a jump have happened. Jump means there is a, whenever we are saying means the patient is having two pathway and the pathways are one pathway has been blocked, another pathway is started conducting. So two type of pathway and the VCS circle is developing. That's why the patient is developing ABRT and AVNRT. So that will be discussed. So thank you for your attention. Okay. Next class we will be discussing again on the this topic and with the revision. Okay.